I know.
It looks like something.
No, it's not as bad right now.
Oh, that's all right.
Nothing. Yeah, we have one to get back. Oh, yeah.
Just look at that, give you the stuff there. Yeah. Hey, Maddie, feeling better?
Kind of, not much.
I'll take that as a no.
Yeah,
Well, get better.
thank you.
There's a handout for today. I'll put it on Blackboard for you, okay?
Okay, thanks.
7 o'clock. All right, gang. Hi. Please take out the handout looking at asthma classification. All right, asthma treatment is going to depend pretty heavily on how you're going to classify the asthma. So to classify the asthma, you're going to use the criteria that you have right here. Now, one of the biggest things that will be important for classification of asthma is, sorry, I'm trying to get these handouts here for Maddie. Oh. Oh, why isn't that? There we go. Okay. All right, there we go. All right, back to the ranch here. All right, so notice when you look at these criteria, one of the biggest criteria is how often does the patient have attacks? So the symptoms of cough, wheeze, chest tightness, difficulty breathing, those are all symptoms of an asthma attack, right? How often do you get them? So if it's less than twice a week, less than twice a week, and if your nighttime symptoms are less than twice a month, you have so-called mild intermittent asthma. Really, the only thing you need at that point is a rescue inhaler. If you look at the FEV, do you remember what FEV means? Did you do FEVs in lab? Forced expiratory volume. You take that device, you breathe in as deeply as you can, you blow out for as long and as hard as you can. It's an FEV1 because it's the amount you breathe out, the volume of air you breathe out after 1 second. That's essentially measured. Forced expiratory volume. So the FEV and the peak flow test, as you can see, they're not affected. So essentially you're getting flare-ups. Those flare-ups are not very often. Twice a month or less, twice a week or less, nighttime symptoms less than twice a month. If they're at that frequency or less, it's mild intermittent asthma. Mild intermittent asthma. Okay, go to the one next. Now you're getting attacks 3 to 6 times a week. So you're essentially almost getting them every day. Now your nighttime symptoms are such that you're having about 1 a week. So you're having attacks almost every day. It says 3 to 6 times a week. Nighttime symptoms almost every week. The nighttime symptoms, they keep you from going to sleep or they wake you up. Still, you'll notice FEV1 and peak flow are still pretty normal. So these attacks are more often than the mild intermittent. You're still not seeing a lot of long-term sort of exacerbation of the ability to breathe. That's mild persistent. Mild persistent. Anytime you have persistent asthma, an inhaled steroid must become a part of the treatment. Moderate persistent, now you have asthma events daily. Not almost daily, daily. Your nighttime symptoms, as you can see, are more often than once a week. So you have 5 or more. So that 5, between 4 and 5 per month, that's the red zone between mild persistent and moderate persistent. Now look at the FEV and the peak flow test. Now you're starting to see compromised ability to breathe. The air exchange is definitely compromised. Moderate persistent asthma will be treated with combinations of medications that we'll get to here in just a bit. If you have, it seems, continual sorts of symptoms, and you have nighttime symptoms frequently, and your FEV falls below 60% of normal. That's the big red zone number there, 60%. You fall below 60%, you're now at severe, persistent asthma, and you start to pull out the big guns. High dose steroids, maybe oral steroids, things like that. So this essentially is how you classify asthma. Your treatment algorithm is very dependent upon your classification. Maddie? Exercise induced? If you get it every time you exercise and you exercise every day, but if there's a trigger and it's exercise, normally you don't have them, that's mild. If you have them outside exercise, now it's mild persistent. But the fact that there's one trigger, it's exercise, could be the cold air you're breathing in, or just the exertion, either or. That's still mild intermittent asthma. That's a good question, actually, because exercise-induced asthma is kind of common in young kids. Amazingly, kids tend to outgrow it. They tend to outgrow it because the airways get bigger. As the airways get bigger, they can tolerate maybe a little bit of constriction, a little bit of inflammation, and it's not of any consequence. There's no compromise to their breathing. Or in some case, kids just, what set them off just doesn't set them off anymore. They become immunologically tolerant to it. That happens too. Okay. Oh, before we start, with the slides, I thought it might be important to maybe view some videos. So this is Nurse Sarah, who's going to demonstrate how to use an MDI, meter dose inhaler. I can't recommend her YouTube site enough. This lady's a pediatric nurse. Her videos are very easy to understand. She speaks very clearly. She has a very obvious Southern twang. She's probably from the South, but her videos are excellent, really well done. There, okay, so we're going to watch, okay, let me make sure Maddie can see this. We're going to watch Nurse Sarah show you how to use an MDI. Turn it on.
Meter dose inhaler. This is an inhaler used to deliver a set amount of medication into the patient's lung. And the medications include like bronchodilators, like albuterol, a brand name for that is like insulin or Prolia, along with corticosteroids such as fluticasone, which is known as respiratory disease. Asthma, COPD may be prescribed these inhalers. Now, these inhalers can also be used and be ordered as a combination where there's one inhaler, but there's two different types of drugs in them, like Symbicort, which would contain a bronchodilator and a corticosteroid. So you want to keep that in mind and always look at what your patient's going to be taking. Another thing is that you want to teach the patient proper technique when using these inhalers. Because if they don't use it correctly, what will happen is that the medication will get down into their lungs. It'll just stay in their mouth. And that is a big issue with some of these medications like corticosteroid. So whenever you are teaching the patient how to use an inhaler, try to get a spacer. This is what it looks like. And it attaches onto the inhaler and they inhale through that, which I would demonstrate in the next video how to use. Always go by whatever the physician has prescribed for the patient. A lot of patients will tell you what they've been using, and you need to make sure that they're doing it right. Now, why would you want to use a spacer? Well, the spacer is going to be easier to use than that. So what we're going to do first is we're going to perform hand hygiene and we're going to perform the patient's 5 rides. We're going to make sure that we have the right patient, the right drug, the right dose, we're doing it at the right time, and the right rack. And you always want to look at what you're giving, because whenever you're doing these inhalers, there's some things you want to keep in mind. Okay, say you were going to be giving a bronchodilator inhaler and a corticosteroid inhaler. So you have 2 inhalers. It's very important to know which one you need to give it first. The first one you want to give is the bronchodilator, because it's going to open up those lungs and dilate that. Then you need to wait 5 minutes and then administer corticosteroid. Because then the corticosteroid can be in there, do a shot by decreasing inflammation. Now, 2 cups of the bronchodilator, and that was it. Or 2 cups of corticosteroids, and that was it. You would first do a cup of the bronchodilator, and say they need another bronchodilator puff, you would wait 1 minute and then give the other one. So if you're giving the same medication, just 2 different doses, you're going to wait 1 minute. But if you were going to give a bronchodilator and then a corticosteroid, you would wait 5 minutes because we need 5 minutes for the bronchodilator to do its job. And then another thing you need to remember is that after the patient uses an inhaler after a corticosteroid, it needs to breathe and gargle and rinse their mouth with water, spit out. Whenever it comes in contact with those mucous membranes in the mouth, it can cause thrush. So it's very important to get your patient to do that. Next, what you want to do is you want to prime the inhaler. So you want to prime the inhaler the first time you're ever using it. If the patient hasn't used it in a week or more, has dropped it, or recently cleaned it. So before you do that, just make sure that your inhaler is in date. It's not expired. So to do that, what you're going to do is you're just going to gently pop this canister off, and it will tell you the expiration date. This is 2020, so we're in date. And the dose that we're using, this inhaler that we're using here, is a demo dose. It's a teaching dose. It does not contain medication. Also, never administer medications to a patient who don't have proper credentials or who do not been trained, and you always follow the hospital protocols. So, another thing, there's enough doses in this inhaler because they only contain so many puffs. So a lot of inhalers have a counter on them, and it'll tell you how many's left, like 20, 10, however many. So look there to make sure you have enough. And if it doesn't say, like this one doesn't, the box will tell you how many sprays are in each inhaler. And this one has 200 sprays. And there's only 200 puffs in this box. How many days is this inhaler going to last? If they do it every day, just 50 days. So you want to keep track of that. Now to calm the inhaler, what we're going to do is we're going to remove the cap, and then just hold with your thumb at the bottom and your 2 fingers at the top, and gently give it a shake. And depending on the manufacturer is how many sprays you're going to spray to prime it, because each inhaler is different. So always read the instructions. With this one, it's 4. So what we're going to do is just do 4 sprays. Now that our inhaler is primed, let me demonstrate for you the open mouth technique. I'm going to tell you about it, and then I will show you how to do it. Okay, so what you're going to do is you're going to have your patient set up, and you're going to have them hold the inhaler in between their thumb and their 2 fingers, and give it a good shake for about 8 to 10 seconds just to mix up that medication really good. Then they're going to measure out 2 fingers width between their mouth and the inhaler, and make sure the inhaler is pointed at their mouth. And what they want to do is they want to breathe in and then breathe out through their mouth until they no longer can. And then after that, simultaneously, they want to put the inhaler down and breathe in slowly through the mouth of the stuff that's coming out of the inhaler. And then they'll want to hold their breath for 10 to 12 seconds and breathe out slowly. If they need another puff, that same medication, they can do it in 1 minute. So let me show you how to do that.
Welcome to TripSitter.com, an alternative solution to treatment-resistant forms of PTSD, anxiety, and depression.
Open mouth technique.
Then after that, recap the inhaler, and if it's a corticosteroid, be sure to gargle and rinse the mouth with water and spit, and perform hand hygiene and document. Now let me demonstrate the closed mouth technique. So what you want to do is hold the inhaler into the thumb and the fingers in the shape of about 8 to 10 seconds. Take the breath in and then out through their mouth until they can no longer exhale. And then put the mouthpiece of the inhaler in between the teeth, keeping the tongue flat and the lips still around it. And they will simultaneously hit the inhaler button and breathe in. 10 seconds, and then exhale slowly. And after this, something like this. This was a bronchodilator and they needed to use the corticosteroid. How long would they wait? 5 minutes. Okay, so that wraps up this video on how to use a meter dose inhaler using the open and closed mouth technique. Thank you so much for watching, and don't forget to subscribe to our channel.
She also has on some of her videos, she has a little box. You click it and it goes to her website. You take a quiz on the video. Her videos are really good. And plus, you gotta admit, she's as cute as a bug's ear. So she's fun to watch. So I really, really highly recommend her videos. A lot of information, really practical stuff in there. So registerednursrn.com is her site. Now, this particular video here shows you how to do a peak expiratory flow rate. It's very easy to do. A British medical student here is going to do it. The chap he's doing it with is another medical student, but he's pretending to be a patient. So we had our Southern accent and we're going to have our British accent.
That's a reading the score of 700. To finish, you just need to take the 2 readings. We'll take the best of all 3 readings and record it in your peak flow diary. Okay. Thank you very much.
The one medical student is to see how he said, You need to sit up, nice and straight. That's Manchester. If you're from the Manchester area, that's what that accent sounds like. All righty. Any questions about peak flow using an MDI? A dry powder inhaler, a DPI, you'll do virtually the same technique to inhale that as well. Dry powder, sometimes patients, the powder is very fine. It can tickle. They can cough sometimes when they inhale the dry powder. So that's just something to be aware of with the dry powder inhaler. Okay. Right, we're talking about, right, okay. Now, this is the day of handouts. Okay. So your beta-2 adrenergic agonists, they come in two classes, short-acting and long-acting. The short-acting ones, they're used as rescue inhalers. Rescue inhalers. If you get an inhaler with a short-acting beta-2 agonist, it will usually have a red cap. So if you need to go through somebody's inhalers, you need to know what their rescue inhaler is really fast. Look for the one with the red cap. Now, the longer acting beta-2s. The FDA has pulled these for mono use. They're always used in combination with an inhaled steroid. So they're only available in combinations now. Reason being is that people who took the long-acting beta-2 adrenergic agonists alone were at higher risk for heart attacks. So by combining them with the steroid, you get long-term control and you don't have to have as high a dose of the long-acting beta-2 adrenergic agonist. So you can see there are 4 of them there. Salmeterol is probably the one that's used the most. But there's also formoterol, formoterol, which is a formoterol is a racemic mixture. The formoterol is a particular stereoisomer, and the olodaterol is probably the newest out of these 4. Big side effect of these drugs is tachycardia. Some people, because they act, they're pathomimetics, they can become irritable on them. The short-acting beta-2 agonists in some people will cause paradoxical bronchoconstriction. That's rare, but it happens. So you see albuterol and levalbuterol. Levalbuterol, again, is a stereoisomer of albuterol. Metoprotrenol is only available in a generic. Terbutaline is used for bronchospasms. It's not used anymore as an inhaled form. So you see there's a sub-Q and an oral form. It doesn't come in an MDI. Now, the third drug on that list, the methylxanthines. So this is the drug theophylline. This drug has a narrow therapeutic window. And you can see that it's a potent bronchodilator, but if you get above that therapeutic threshold, you're going to have arrhythmias. And those arrhythmias can be deadly in some patients. Because of that, this drug is only used for emergencies. It comes in an oral form, it comes in an inhaled form, and it comes in an IV form. Aminophylline that you see there is theophylline. It's just in a IV form. So this one's for emergencies. Now, for kids, this drug used to be given long-term for kids. It causes learning disabilities if kids are on it long-term. So it's never used long-term for kids. All right, questions so far? Good? Again, if someone has an episode and they can't breathe, epinephrine is your go-to for an asthmatic emergency always. Don't give Benadryl. That's kind of an urban myth out there. Oh, they're having a, drop something, Emily? It's just kind of an urban myth that if someone's having a reaction, oh, give them a bunch of Benadryl. There's no evidence Benadryl will pull someone out of an asthmatic emergency. Epinephrine and only epinephrine is the drug that's been shown. Comes in an injector and give it in the quad. All right. Because the vagus nerve innervates the airways, and activation of the vagus nerve will induce bronchoconstriction. There are some inhaled drugs that are antimuscarinics. So they will block the muscarinic receptors on the surface of smooth muscles so that acetylcholine cannot bind to those receptors and elicit bronchoconstriction. So these will cause bronchodilation. These are used predominantly for chronic obstructive pulmonary disease and people with emphysema or folks with chronic bronchitis. These are not first line for asthma, but you can combine these with other drugs if someone has severe asthma. So if we look at these drugs, ipratropium is short acting. Ipratropium is wonderfully cheap. That's usually why it's used. But it's short acting. These other two, aclidinium and tiotropium, are long acting. And notice they tend to come in as dry powder. So they're given in dry powder inhalers. Ipratropium also comes in a liquid form you can put in a nebulizer. Who doesn't know what a nebulizer is? Everybody knows a nebulizer. Excellent, excellent. Okay. Drugs for nebulizers, they come in plastic ampules. They're liquid. You shake them, tear off the top, and you pour it into the top of the nebulizer, turn it on, and then the patient just breathes, essentially. There's usually enough drug in there for about an hour, usually. So your muscarinic antagonists, the antimuscarinics, you don't use them for short-term relief. They're much better for long-term. They do nothing to knock down inflammation. That's the other piece about the beta agonists. They relax bronchial tubes, but they do not hit inflammation. And remember, what causes remodeling in the airways? Inflammation. Inflammation. So if you have persistent asthma, that means you've got low-level inflammation in the airways. You need to quell that inflammation, or you're going to get remodeling of the airways. And that is one of the big goals of your treatment, is to prevent remodeling and also to prevent flare-ups so that the patient can live a normal life. So here are just some structures of ipratropium, tiotropium. Remember, tiotropium, long-acting, ipratropium, short-acting. All right, on page 2, you can see some combination drugs. And you can see ipratropium comes in a combination with albuterol. Combivent is usually the name of that combination. That comes in an MDI. And then these other drugs up there, you have anticholinergics that are combined with long-acting beta-2 agonists for long-term control. Euclimidium and bilateral and olidoterol and tiotropium. So long-acting beta-adrenergics, long-acting beta-2 agonists. Very good. Please turn to page 5. Page 5. Your oral or inhaled corticosteroids will stop inflammation. So your go-to is usually for persistent asthma is an inhaled corticosteroid, usually low dose. If that doesn't work, then you bump it up to medium dose. With low and medium dose, you don't get systemic side effects. So you see the list of these different types of inhaled corticosteroids: beclomethasone, budesonide, flunisolide, fluticasone. Fluticasone is probably one of the most widely used ones. Mometasone, triamcinolone, and ciclesonide. Ciclesonide, once it gets in your lungs and it acts, it breaks down in the lungs. So none of it is absorbed systemically. That's a special steroid that was developed for that purpose. If these don't work and you have to go to an oral steroid, these are the ones that you use, pill or liquid form. They're listed there. The go-to is almost always prednisone. Prednisone is widely available. It's very cheap. The pills are scored. You can cut them. Big thing to remember about prednisone. You always step someone off prednisone. Anyone remember why? What's prednisone do to your adrenal cortex? Pituitary releases adrenocorticotropic hormone. This goes to the adrenal cortex. What's this make? Glucocorticoids. And it makes mineralocorticoids. This then feedback inhibits the release of ACTH. Also feeds back on the hypothalamus as well. We give prednisone. What's prednisone do? It thinks it's corticosteroid. It shuts this down. That's why you step someone off prednisone gradually. If you go cold turkey, they're going to start having the symptoms of Addison's disease. So I step them off. If they're on 40, you step them off to 30, and then 20, and then 15, and then 10, and then 5, and then off. They're on 80, 70, and 60, and 50, then 40, so on and so forth, blah, blah, blah. Always step people off prednisone, always. Unless they're on a really low dose. They're on like 10 mgs, you don't need to step them off. It's not high enough to mess with their pituitary adrenal axis. All right, so those are the structures of your inhaled corticosteroids. Those usually come as dry powdered inhalers. And you can see the trade names here. Fluticasone is available over the counter now, at least intranasally. It's available over the counter. And so is mometasone. That's available as a nasal spray also over the counter. Oral steroids, of course, they have a lot of side effects. You don't want to keep someone on these over long periods of time. One of the other drugs that can help long-term are drugs that antagonize the leukotrienes. So leukotrienes are released by mast cells, whereas histamine works quickly. Leukotrienes work more slowly and more potently. They bind to leukotriene receptors, and there's several of them. These are potent white blood cell attractors. They're potent vasoconstrictors. They're potent remodelers of the airways. Anti-leukotrienes, the big gun here is montelukast, which goes by the trade name Singulair. These other drugs that are available have been discontinued in the US. Zafirlukast you can get in Europe, you can't get it in the US because it was linked to liver dysfunction. Now, montelukast has a new black box warning that was just published last year. Some people experience suicidal ideation on it. So, what are you going to ask your patient if they're on montelukast? Come on, say it. Have you had thoughts of hurting yourself? Have you made plans? Are you down? Do you know those sorts of questions? Montelukast is oral. It's an oral medication. Also works well in children. And they work here. They work at the level of receptors. So you can see where the glucocorticoids work. They prevent this whole cascade from even getting started. Once you make the leukotrienes here, they bind to receptors. But Montelukast singular, that's what it prevents. And this drug also plays well with other medications. You can combine it with other medications if you're trying to treat your more persistent forms of asthma. And this is their structure, just to show you a structure. All right. Questions about any or all of those before we go on to the biologics? Sorry? Primatine? Oh, primatine. Primatine, that's inhaled, that's over the counter. That's inhaled epinephrine.
Yeah, you can take it orally. It's also used for asthma.
It is used for asthma and it's available over the counter, and some people it works really well. So yeah, that Primatine is a over the counter. I'm almost sure there's not a prescription version of it. I think it's completely over the counter. Yeah, yeah. So yeah, Primatine, it was called Primatine Mist. I think it's still called Primatine Mist, or is it in generic now?
Yeah, they're called mist and tablets. I don't know if it's called that anymore.
Okay, I'm not too savvy with the research on the tablets. The studies that have been done with the mist are very favorable. It works quite well.
Yeah,
Tablets,
That's pretty.
yeah. Epinephrine in general is a very short-lived drug inside your body. Doesn't last long at all. All right, biologics. What page are we on here? Okay, here we go, page 4. If somebody's asthma is very allergy-based, there is an injection. It's given subcutaneously. It comes in an injector like this. It's called omalizumab. Goes by the trade name Xolair. This medicine, unfortunately, is very expensive. This is an antibody against immunoglobulin E. So it prevents mast cell degranulation because it prevents mast cells from being bound by immunoglobulin E. Again, given subcutaneously, the patient gets a injector. Omalizumab is usually taken once a month. For some patients, it gives them a new lease on life. People who've not had asthma that's controllable by other means, this drug works really well. Now, before the insurance will pay for this drug, usually, you have to demonstrate that you failed with other drugs. So one of the downsides of the biologics, they're not cheap. Okay, so a month's worth of treatment, so that's one shot of omalizumab, is $1,100. That's why the insurance company says you've had to fail with everything else before they'll pay for it. They will pay for it. We've had students here who have been on omalizumab, so they will eventually pay for it. To prevent mast cell degranulation, yeah, Hannah. Yeah, I'm going to talk about Dupixent. Yeah. And atopic dermatitis as well. It was approved for that 2020. Yeah. To stabilize mast cells, there are these drugs that are inhaled. And the drug that's normally used is cromolyn sodium. Cromolyn sodium is available. It's also available over the counter. It's preventative. It's prophylactic. It's not, you can't use it when you have a attack. It's just used to prevent it. They go to the mast cells, they prevent mast cells from degranulating. Fewer and fewer doctors are using this drug because it doesn't work all that well. All right, let's talk more about some of the big gun biologics. Some people have a type of asthma called eosinophilic type asthma. Eosinophilic type asthma is remarkably difficult to treat, and it typically is very severe. If you failed with all these other drugs and you have eosinophilic type asthma, there are biologics that will attack interleukin-5. Now, interleukin-5 is released by T helper 2 cells. When they're activated asthmatics, they will recruit and promote the proliferation and survival of eosinophils. Eosinophils will then be recruited to the airways, and they will do a lot of damage to the airways. These drugs prevent interleukin-5 signaling. And they hamstring the eosinophil response. So these are antibodies. 2 of them are given sub-Q. They come in injectors. One of them, rislizumab, you see there, is intravenous. You have to come in and get infusions of that particular drug. So it's not as convenient. So benralizumab, Fasenra, is a monoclonal antibody against the interleukin-5 receptor, against the receptor. So it binds to the receptor, prevents it from the eosinophil from receiving the interleukin-5 signal. So the eosinophil will die because it needs interleukin-5 to survive and proliferate. Mepolizumab, Nucala, binds to interleukin-5 itself, prevents it from being able to bind the receptor, and prevents it from working. Both mepolizumab and benralizumab come in injection pens. They're given subcutaneously. A month supply of benralizumab is $5,000. A month supply of mepolizumab is $3,000. Not cheap. Benralizumab you take once a month at first, and then after the first 3 shots, you take it once every 2 months. Mepolizumab you take once a month. Reslizumab, Syncare, you take once a week. You have to come into the doctor's office to get it because it's an intravenous infusion. The biggest side effect of these drugs is bruising at the injection site. People who get on these drugs can reduce their use of oral steroids, and they have their asthma controlled quite well. They're also, on the average, these drugs very well tolerated. And I see it's past our break time. So we'll take our break. We'll talk about Hannah's favorite drug here, dupilumab. So you can see this one does double duty with 2 different interleukins. And then I want to tell you about a drug that just got approved 2 weeks ago. And that's this one here at the bottom of page 4. See, we give you up-to-date information here. Okay, take 5, and then we'll resume. Finish this, and then talk about allergies. Finish this out, and then get into cardiac drugs. Okay, let's resume. Interleukin-4 and interleukin-13 bind receptors that use a common subunit. And if I show you this picture here, the subunit that's labeled interleukin-4 receptor alpha, that particular subunit is used both as a receptor for interleukin-4 and for interleukin-13. They just have different partners. This particular antibody, dupilumab will bind to that interleukin-4 alpha receptor subunit. It will render that receptor inactive and unable to bind to either interleukin-4 or 13. These particular interleukins are necessary for the maintenance of asthma. If you inhibit these receptors, you can inhibit asthma. Again, they tend to work best in people with eosinophilic type asthma. So this again, it is given as a subcutaneous injection. So it comes in an injector pen. And the Liberty trials used dupilumab in people with severe asthma and people with eosinophilic asthma. You can see that all these markers of asthma and inflammation in the airways were decreased. Furthermore, the drug was quite well tolerated. The most common adverse effect was injection site reactions. Those are seen in close to 20% of the people. Other things that were seen, conjunctivitis, things like that, rare, very rare. And then a couple of years later, the FDA approved Dupixent for severe atopic dermatitis, but only in patients who are 18 years old or who happen to be older. At the bottom of page 4, there's a new drug that was approved by the FDA just a couple of weeks ago. And that is this drug whose trade name is Tezspire. Tezspire. This particular antibody inhibits the thymic stromal lymphopoietin. What on earth is thymic stromal lymphopoietin? This is one of the very first proteins made by T helper 2 cells that activates the pathway that leads to asthma. So this is very early in the asthma pathway. So these come as single dose pre-filled syringes. It's injected subcutaneously. You get it once every 4 weeks. And it is $3,630 a shot. That will almost certainly come down. The beauty of this drug, it works on any kind of asthma. Eosinophilic, neutrophilic, mixed. Will work on any of them. Main adverse effects, as you can see there, were soreness of the throat, soreness of the joints, and back pain, none of which lasted for very long. Okay, are there questions at all about the drugs for asthma? No? Let's talk a bit about drugs for allergies. So take a look at page 2, please. Your big gun drugs for allergies are your antihistamines. So this is the H1 receptor. When we look at drugs for the GI tract, we'll look at H2 receptors. Those are in the GI tract. They're involved with the secretion of stomach acid. Many of those are available over the counter, the H2 receptor inhibitors. These are H1 receptor inhibitors. Jenna, is that a question? Or you're just holding your arm that way? No, you just, okay, never mind. No, it's all right, you can hold it up. I just wanted to get a question. Now, there are 2 types of antihistamines. First generation, second generation. First generation antihistamines tend to be very lipophilic. They cross the blood-brain barrier and they're sedating. They also have anticholinergic effects. The most popular one, of course, is diphenhydramine, which is very inexpensive and is available everywhere. It comes in a pill, comes in a syrup, comes in dissolvable tablets, comes in, yeah, all over the place. Most allergists will tell you there are better drugs, don't use these. Some people use these as sleep aids. You shouldn't use them as sleep aids. Turns out they interfere with REM sleep because of their anticholinergic effects. And acetylcholine is necessary for REM sleep. Because of their anticholinergic effects, these drugs can cause your mouth to be very dry when you wake up. So they're sedating and they cause dry mouth, and they might cause, in older people, they can cause confusion and stuff, not good. Second generation drugs. These drugs don't penetrate the blood-brain barrier. They're not sedating. And they're on the average remarkably well tolerated.
really long versions of like ferritin? Or they have carcinogens?
Because they're newer.
Okay.
Because they're newer, the data is not yet available to establish their safety to make them over the counter. It's only a matter of time. Though. Also, the drug company, their patent has to essentially expire before generic versions can be made. And if the FDA deems those generic versions safe enough, it'll just put them over the counter. For example, azole-aston, which is available as a nasal spray. FDA just made azole-aston over the counter. It hasn't really appeared yet on the shelves. I've been looking for it, but it's been made over the counter. It's only a matter of time before it appears. So some of these others like levocetirizine and desloratadine, those are still under patent. So fexofenadine, cetirizine, loratadine, those are all over the counter now. They're very safe. Olopatadine is only available ocularly. That drug is now over the counter. Ketotifen is also available over the counter. That's only available ocularly. So your third generation drugs, as you see there, they're available by prescription. The others are available over the counter. Loratadine comes in a tablet that dissolves. You put it on your tongue and it dissolves. It's called Alavert. If you don't like swallowing pills, you just put it on your tongue and it dissolves. So the skinny on those essentially is used second generation antihistamines. Especially now, they're over the counter and they're cheap. They're cheap. Don't mess with the first generation ones. You don't need them. They don't work any better than the second generation ones, and they have a lot more side effects than the second generation ones. Okay, the table above are drugs essentially for cough. So the main drug, as you can see there, is going to be dextromethorphan. Dextromethorphan is an opiate, but it doesn't penetrate the blood-brain barrier terribly well, unless you take a lot of it. Then this other drug is guaifenesin. That's the one that goes under the trade name Mucinex. Extended release Mucinex should not be given to children, adults only. Dextromethorphan, if you take it as indicated, it's pretty well tolerated. If you take too much of it, it'll make you pretty loopy. Antihistamines can prevent cough because they decrease the secretions that go down the throat and cause a cough. By combining them with antitussives, cough medicines, you get an even better relief of coughing. Codeine, as you can see, is a very good cough medicine. Codeine, of course, in this country is only available by prescription. You can get codeine over the counter in Europe. Can you still get it in Canada? You used to be able to get it in Canada. I think the Canadians pulled it. You used to be able to get it in Canada. I'm not sure you can anymore. You used to get a drug, it was called 222s. They had codeine, aspirin, and acetaminophen for a cold. People used to go across the border and buy them and then bring them back up to the United States. It's pretty low dose codeine. Hydrocodone, you can see, is combined with this drug homatropine. That's to prevent overdosing on it. Pseudoephedrine is used a lot as a decongestant for cough. There's no evidence that pseudoephedrine helps with coughs. There's another medication you might have heard of called Tessalon. Have you heard of Tessalon? Benzonatate, Tessalon, is an anesthetic. Because it deadens the throat, it prevents coughing. The problem with this drug is its side effect profile. The tablets, because they're colored, kids mistake them for candy, and kids have been poisoned on this drug. Because of that, the FDA has urged against prescribers prescribing that drug. It definitely should not be prescribed to people with small children in the house, because one tablet can kill a kid. If taken as directed, the side effects of these are not very. Guaifenesin, if you take too much of it, you can get dizzy and you can get drowsy, you can get a headache. If you take it for a long time, it increases your risk of kidney stones. Beyond that, it's quite safe and well tolerated. All right, that is pretty much everything about antihistamines, asthma drugs. Are there questions? Yep. All right. And now we're going to downshift drastically and look at something very different. Decongestants, guaifenesin loosens mucus so it can be coughed up. Doesn't prevent the production of mucus. The decongestants, so like the alpha-1 agonist, those are available as sprays. Now, right, Afrin, those, thing about sprays, they should use sprays 4 days, no longer, because if you use them longer, your nose actually becomes dependent. So 4 days, and then after that, no more. Sorry?
No first question.
It's on the handout. Those aren't, the nasal sprays are essentially to prevent the waterworks, essentially. Because the alpha-1 agonist essentially will prevent mucosa. Also, because you give them intranasally, the amount of systemic absorption you get is not very high. So you don't get the rise in blood pressure and the vasoconstriction that you get from them if you took them systemically. But again, 4 days, no longer. Otherwise, you get this massive rebound congestion because your nose actually doesn't depend on it.
Sure.
Okay, cardiac medicines. Let's do the worst ones first. The antiarrhythmic drugs are a bummer. They're hard to understand. So some of this is meant to be a little bit on the lighthearted side, to hopefully give you some ideas. So there's 4 classes of antiarrhythmics, and they're mercifully called class 1, 2, 3, and 4. The class 1s are broken into 1A, 1B, and 1C. You'll see why here in just a bit. Each of these works in a different way. So if you consider the action potential of cardiac muscles, so just quick review on the electrophysiology of cardiomyocytes. Your resting membrane potential is around minus 90 millivolts. When you get activation, usually it's the influx of calcium from the cell next to you because you're attached to that cell with gap junctions. So ionic changes in one cell spread immediately to the next cell. You have a depolarization to threshold. Your voltage-gated sodium channels open, and they open lickety-split. Look at that depolarization. Isn't that fast? And you depolarize up to about plus 20 or so millivolts. Once you get up there, your voltage-gated sodium channels close. That is so-called phase 0. Phase 0, the depolarization that is voltage-gated sodium channel mediated. Now you get your voltage-gated potassium channels opening. So remember, sodium is high outside the cell, low inside the cell. You open a sodium channel, sodium is going to come into the cell. You open a voltage-gated potassium channel, potassium is going to flow out of the cell. Sodium flows in, it depolarizes the cell. Potassium flows out, it repolarizes the cell. Repolarizes the cell. All right, so the potassium channels open, you start to repolarize, but then something starts to mess with the repolarization. What happens? Your L-type voltage-gated calcium channels, they open too. Calcium levels are very low inside the cell. Calcium now runs into the cell. Now you've got a fight between potassium and calcium. You need calcium to contract if you're a cardiomyocyte, right? Because of that, you get a so-called plateau phase. So your repolarization is phase 1. Your plateau phase is phase 2. Phase 2. Once you get your contraction, the voltage-gated calcium channels will close because potassium is still leaving the cell. You'll now repolarize. That's stage 3. And then you go back to resting potential, stage 4. So stage 1, voltage-gated sodium channels open. You depolarize. Sorry, phase 0. Phase 1, voltage-gated potassium channels open and the voltage-gated sodium channels close. Potassium now leaves the cell. You start to depolarize. Phase 2, L-type calcium channels open. You now have a plateau phase as calcium starts to enter the cell to allow the cell to contract. The voltage-gated calcium channels close and potassium continues to leave, repolarizing the cell. That's phase 3. And then you're back at resting potential. Resting potential is phase 4. Phase 4. Okay, with me so far? All right. Hannah, phase 4. What happens at phase 4? You're at resting potential. Emily, what's resting potential in a cardiomyocyte? Minus 90, what are the units? Millivolts. Good job, millivolts. Erica, phase 0, what happens? Depolarization. Depolarization. Haley, depolarization is due to the opening of what? Voltage gated, what ion? Sodium. Sodium, say it. There you go. Voltage gated sodium channels. Voltage gated sodium channels. Jenna, what happens at phase 1? Good. Repolarization is initiated. Good. And what closes? Good job. Good job. Clara, plateau. Phase 2. What happens at plateau? There you go. They kind of fight. They argue with each other. Good. Emily. Sorry, not Emily. Sydney. The other Emily. Sydney. Phase 3. What happens at phase 3? Which channel closes? Calcium. Say it. Calcium channels close. You repolarize, and then you get to stage 4, and now you're back at resting potential. All right. Class 1 antiarrhythmics are going to mess with voltage-gated sodium channels. They're going to mess with voltage-gated sodium channels. Now, your class 1A antiarrhythmics, they inhibit those channels, but they inhibit it in a state-dependent manner. It's in 2 different states, open and closed. They bind to cardiac tissue that is actively depolarizing. Therefore, they bind to the sodium channels when they are open or closed. Open, open, good job, open. Because of that, the 1A group, they are most selective for the parts of the heart that tend to be the most out of whack. Parts of the heart that are overreactive, that's the part that they're usually the most selective for. So these inhibit sodium channels both in the atria and in the ventricles. So they slow depolarization. Instead of that phase 0 being like this, they're going to take phase 0 and they're going to do this to it. So essentially, if you turn the page, if you look actually at page 3, it shows you essentially how that electrophysiological graph is altered. All right. These drugs may also block the potassium channels, causing a slower repolarization. Okay, now do you see the little squirrel? That little squirrel is a QT. And so they cause an elongated QT wave. QT wave, get it? So every time you see the little squirrel, the QT squirrel, that means it causes elongation of the QT interval. The 1A drugs, there's 3 of them. Quinidine, procainamide, and disopyramide. Quinidine, procainamide, disopyramide. You're going to avoid these drugs like the plague in people with heart failure. They'll make the heart failure a lot worse. Procainamide is the first line drug of choice for Wolff-Parkinson-White syndrome. Wolff-Parkinson-White syndrome. In Wolff-Parkinson-White syndrome, you have an extra, so normally the beat goes from the right atrium, from the SA node to the AV node, down through the bundle of His. It splits and then goes up the Purkinje fibers to either side of the heart. And there it stays. With Wolff-Parkinson-White syndrome, you have an extra conductive system that goes back up to the atria. So you get reentry. And you're subject to pretty severe tachycardias. People are born with that usually. Procainamide's drug of choice for Wolff-Parkinson-White syndrome. Now, are you guys familiar with torsade de pointes? Let's review the EKG. What's a normal EKG look like? P wave, good. Okay, P wave. And then the QRS, and then the T wave. And then it just repeats. Now, this is atrial depolarization. This is ventricular depolarization. This is ventricular repolarization. If your EKG looks like this, that's torsade de pointes. It's French for turning of the points. This leads to asystole. This leads to death. This is very bad. Torsade de pointes. And if you see the ribbons, those ribbons, wavy ribbons, that's meant to be an EKG with torsade de pointes. That means it causes torsade de pointes. All three of these drugs will cause torsade de pointes. An elongated QT wave can lead to torsade de pointes. That's why an elongated QT wave is potentially dangerous. We're out of time. Okay, bring this with you on Wednesday, please. We'll go through these and then we will hit the drugs for blood pressure, drugs for heart failure, and drugs for angina, which are pretty much all the same drugs, it's just different indications for them. Okay.